Good afternoon, good evening, and good morning, colleagues from wherever you're joining us from. And welcome to this special session that we have co-organized with the Global Fund and the Supranational Reference Lab of Benin. We are really grateful that you made the time to join us. And before I hand over to our Director of Programs for the opening remarks, I'll just give you a few housekeeping items. The session is being recorded. It will be for 1 hour. You could please select the channel you wish to be in, either English, Portuguese, or French, and you'll receive the appropriate interpretation. Should you wish to receive a certificate of attendance for the session, it will be emailed to you at the end of the session or a day later. In that email, you'll also receive a link to any resources that we'll have from this presentation. So again, welcome. And I will hand over to our Director of Programs for the opening remarks. Over to you, Dr. Maruta.
Thank you very much, Dr. Lucy. And good morning, good afternoon, and good evening, colleagues. On behalf of the African Society for Laboratory Medicine, I would like to really take this opportunity to warmly welcome you to this very important and also very timely echo session on accelerating TB diagnosis in Africa, spotlighting mostly on near point of care diagnostics, and this session being co-hosted by ASLM Global Fund and also the SRL from Benin. So as you all know, colleagues, that close to 47% of the global population has very little to no access to diagnostics, as you may have read from the Lancet Commission. And this particularly affects the poor, the rural, and also the very marginalized communities. Hence, the need for us to come up with strategies as experts on appropriate access and equity, as well as social justice when it comes to access to diagnostics. And in order to address this issue of access and equity, point of care testing becomes one of the key drivers in this patient-centric diagnostics. And in this also assures that the issue of access is addressed by ensuring that services are available at the lowest possible level of care, especially in those underserved areas. Also, this point of care testing will also ensure timeliness when it comes to rapid turnaround of results to be able to support immediate clinical decision making. And of course, the issue of equity by bringing diagnostics, by bridging that gap when it comes to diagnostics, particularly to those populations that are vulnerable. So in this webinar, colleagues, we will discuss strategies to prepare for the next generation of TB diagnostics near point of care molecular tools. Just to speak about some of the work that we have done at ASLM and some of our partners that are here, we have been supporting diagnostic network optimizations as well as lab mapping to be able to help countries better understand their networks, help countries to identify as well as close gaps across the entire testing cascade. In this panel today, we have very renowned experts who have experience in this space, and we have been working together with also partners such as Global Fund, which we are co-hosting this session with, CHAI, as well as Find, particularly on market shaping initiatives that are meant to generate that demand that is needed to ensure countries are ready for adoption for some of these tools as they become more and more available. So in today's discussion, part of it is also about the ongoing work, which will allow us to be able to define some of its potential use, as well as knowing that each country will have different needs on its diagnostic networks. We then need to discuss what is the best way forward. Some of these conversations that we have today, that we've had before, and that we'll continue to have, will contribute towards our upcoming annual meeting, which will be hosted in October in Nairobi, where we'll look at concretizing some of the pathways towards universal access, as well as universal access to rapid molecular diagnostics. So without wasting much of the time, I would like to wish you a successful meeting, impactful and action-oriented deliberations, and look forward to the insights that will emerge from this meeting as we go forward. So thank you very much, and please have a successful discussion and deliberation. Back to you, Dr. Lucy.
Thank you so much. Thank you so much, Dr. Maruta, for those opening remarks. Now it's really my pleasure to introduce Dr. Grania Brigden, who is the Senior TB Advisor at the Global Fund, and she'll provide an overview of these new molecular tools that will be at near point of care. So over to you, Grania, and thank you for being here.
Thank you, Dr. Maruta and Lucy, for the very kind introduction, and really looking forward to the conversations from today's webinar. So I think just what I'm going to briefly overview is when we say near point of care or NPOCs, what are we talking about? What do we mean by near point of care? And then what is the pipeline? And then begin to just start to introduce some of the implementation approaches and considerations for these new tools, which then Professor Disu will continue to build upon. So I think I am probably preaching to the converted here. We are all aware of the challenges that we face in TB. So we continue to have 2.5 million people undiagnosed, and only 48% of people globally are diagnosed with the WHO rapid molecular diagnostic test. And the challenges we have is that our current molecular diagnostic tests are associated with high costs, requiring centralized or significant infrastructure such as stable power sources, air conditioning, which means that the ability to take the test to where the people with and at risk of TBR is increasingly challenging. And so these near point of care tests offer us a real potential to increase the access to the TB molecular diagnosis and allow us to move in more settings to a same-day diagnosis and treatment approach, which could help decrease loss to follow-up and start same-day treatment and initiation. But when we say near point of care tests, what is it exactly that we're talking about? And the WHO has developed a very clear target product profile for this particular class. And so we're looking at an instrument that could be battery operated and not require any particular special infrastructure. Intended purpose, obviously, the focus is to detect TB. Pulmonary TB would be the first point of care, and that it can support it at a peripheral, support the diagnosis at a peripheral structure and support same-day treatment. That it should be able to be used by low-level healthcare workers, so not require advanced lab skills like pipetting or detailed sample processing steps. As I was saying, sort of taking it outside some of our more complex or lab infrastructure. And then as we decentralize, as we've seen in other disease areas, we should also be looking at cost reduction. So the target product profile outlined that any instrument for a near point of care test should be around the $2,000 mark, and that the test would be ideally or $6 or less, but really optimally under $4. We know that as we move out of kind of complex diagnostic instruments, we may need to think about a slight decrease in performance. So the WHO, that if we're outline some sort of characteristics with regards to if we remain using sputum as a sample, then we really should be looking at sensitivity of 85% or more. But if there's a non-sputum sample, this could potentially decrease, and that the time to result is under an hour, but ideally much shorter than that. So this what the sort of target product profile is. And the good news, and the reason why we wanted to sort of have this webinar with you today, is that the pipeline is looking very hopeful and imminent. So some of the sort of pipeline work that we've been doing with partners has shown that there could be multiple suppliers who have got products that they think meet these requirements and could be available for less than $1,000 per instrument and potentially less than $4 per test within the Global Fund GC8 period. And these are some of the tools that are in the immediate pipeline. And they're very similar to the low complexity NAT. We see within this class of diagnostics, there are different criteria, sort of the products are not all cut and paste, but they offer slightly different product characteristics that will allow choice within this class to make sure that you can have a product that addresses the particular problem that you have. And a number of these products are also looking at other tests as well. So not just a test for TB, but really thinking about the whole lab diagnostic approach. So a multi-disease platform. But today I'll be talking to you about the platforms that can offer a TB test. Now, those of you who tuned into the webinar earlier this month with Dr. Monday from CIDRAS will have seen the really exciting data that she presented on two of the four sort of the most imminent near point of care platforms, the Plus Life platforms and the TrueNat Ultima. I have just taken a snapshot. I will thoroughly recommend that you access her Echo session to find out more about about the data behind these tools. But what you can see here, and I think what is the most exciting part from this, is that the high sensitivity when these samples use a swab in sputum approach, which is really very similar to the current sort of gold standard low complexity NAT tool we currently have, which is the Expert. And then you can see, as we were saying in the target product profile, there's a slight dip in sensitivity when it comes to the tongue swab. But as we're looking to decentralize these to potentially really replace the diagnostic microscopy, it's significantly, either sputum or tongue swab is offering much more accuracy than the sputum smear. So I think this is why these two products really are, and this whole class is very exciting to us. So as these products are going to, there's a WHO guidelines development process ongoing with an expected meeting in November. We've been working with, and I hope that a number of people on the call were able to join the ASLM special convention last year in Côte d'Ivoire, where we had a TB day where we really sort of began the conversations around what this potential class of diagnostics can offer. And then what do we need to think about planning to introduce? Because we know this is an entirely new class. So this is not a new tool in the low complexity NAT class. This is not a new high throughput. This is an entirely new class that offers us really a new way to think about things, but that means it needs to be planned for. And so the feedback from the meeting last year and the countries that attended was really kind of reiterating that as this is entirely new, we need to think early and we have to think comprehensively about how we introduce this tool. We need to start thinking about some use cases, and I'll come to that in a moment on kind of what the countries fed back to us and last year of looking at that target product profile, where they feel this class of tests can really start to offer some sort of benefits to your diagnostic program. And then also acknowledging that as this is a new tool, the data that was presented in the last ECHO session and is presented, and I just gave a quick summary of, is very much from the research field, so sort of accuracy. But from the program side, there's a lot more sort of programmatic questions. Will this have any effect on diagnostic yield? What are the use cases? How will it fit into your algorithm? What are the patient preferences? When should you use tongue swab versus sputum swab? So these are all sort of implementation questions that may not at this early stage have all the answers available. We again talked about, as we decentralize TB diagnostics, we have to make sure that we in parallel think about where treatment and initiation can start, so we can really be thinking around this same day treatment initiation. We need to be planning for training needs, capacity building. What impact will this have on the various diagnostic workflows at the primary healthcare, microscopy, district, etc., the whole way through? We don't have exact prices, but these platforms are looking significantly cheaper than the low complexity NAT class platforms, and the tests that they offer are also taking quite a considerable drop. But that is the cost, but we need to really, the cost effectiveness data is really still to be still to be outlined. And we also need to think about the quality assurance processes for these new tests and how to ensure that the right processes are in place to allow them to be imported and introduced. And then importantly, both of these platforms are offering a TB, not TB test. So we still need to think about the quality of the whole diagnostic cascade. So linking it, there remains that need for thinking about your whole diagnostic network, sample transportation, but this can maybe take some of the diagnostic time pressure off the sample transportation, where you now then would do a reflex test for drug sensitivity when and if a positive sample is found. Very quickly, out of these country dialogues, sort of three overarching use cases began to come out from talking to the lab and TB program. So I think the kind of lowest cost of change is, could these tests, particularly when you see the data on a swab in sputum being very similar to our low complexity NAT platforms, do we just put these tests in the current low complexity NAT labs, and they are the first test, and then you reflex into your your existing low complexity NAT for drug sensitivity? And then, so this is kind of low cost of change. There could be some potential financial savings, but we might not be having minimal impact on the notifications because it's still in the lab infrastructure where we have our current low complexity NAT. I think thinking bolder, and this is where we're very interested to kind of work with countries to think about, is can we improve the quality of diagnosis? So we know that 52% of people do not get a WRD as their first test for TB, and there's considerable reliance still on sputum microscopy, or people are unable to present the sputum sample, so have a clinical diagnosis. So what if we use these tests to sit next to diagnostic sputum microscopy? So we remained having the microscopy for treatment follow-up, but we have a molecular test that sits next to the microscope for those to diagnose. And then we can also offer a tongue swab for those who are unable to produce a sputum sample. And so here we're improving the quality. So and as you saw from the data slide, even before you start fitting that into any active or intensified case finding strategies, we have a much more accurate test. So we will hopefully be finding more people with TB. And these infrastructures, the diagnostic microscopy infrastructure, is already linked to treatment and initiation. It has people who are aware of TB, and they have the sample. If they don't have a low complexity NAT on site, they should hopefully be linked to sample referrals systems already for drug sensitivity testing. And then the sort of broader long-term aim is really seeing how these new tests can help us take TB diagnosis outside any form of lab infrastructure. This comes with a probably much more considerable cost of change, because we then have to look at all the HR, infrastructure, task shifting, treatment and initiation. But I think we can see, maybe not with the immediate burst in the pipeline, but in the pipeline, these are some of the things that we really can be already beginning to think about how to fit into your diagnostic networks. Just sort of quickly wanted to sort of consider around the data with regards to sensitivity is really quite strong. But if we are able to offer tongue swabs, there is that concern. Well, they are not quite as accurate as the sputum and the molecular, sort of the low complexity tests that we currently have. But if you really think about what this test can offer with regards to increasing access, actually, and I won't spend too long on this, but actually we may end up finding more people with TB because we are the pool of people that we can therefore offer a test for TB is considerably larger than the, so that's the graph on your left, is there sort of this pool of people who can be, who has access to a test via the tongue swab, and sputum swab is much larger than the blue box on the right, which is people who only can access tests with the sputum sample and the sample transportation that gets them to a low complexity NAT. So I think sort of just really thinking about through this process, we need to think about trade-offs and which test is the right test for the problem that you have, because this isn't a swapping test, that this is an entirely new class. So it's an opportunity to see and build on the work that ASLM and other partners are doing around knowing your network, knowing your challenges, and then we now have new tools coming into the pipeline that can really sort of help us think about which is the right test to address your problem with regards to cost, with regards to access, with regards to quality. So so I think just to conclude quickly is that this is very exciting, that we don't foresee that there'll be a one-size-fits-all for how this new class of product will be introduced. It will be very context-specific, and knowing your diagnostic issues will really help you make sure that you choose the right tool for the right impact. As I was saying, there is we may have to think about some trade-offs, but improving access may make those trade-offs easier because we're getting increasing coverage of our diagnostic network. At the moment, the products in the pipeline do not offer drug sensitivity testing, so there still needs to be that consideration for sample transportation and utilizing your existing network of low complexity NATs and high throughput platforms for the quality diagnosis. But as the majority of people have drug-sensitive TB, there is still the potential that an accurate molecular diagnostic test at a decentralized level can allow for same-day treatment and same-day treatment starting. New test always involves training and capacity building, but part of the target product profiles is this test is looking like it will be a lot easier to implement. It can be done by non-lab staff, but it still needs to be factored into your planning. And then we need to really make sure, as exciting as this is, we don't increase coverage and decrease quality, but we do it in parallel. Thank you very much.
Thank you so much, Grania, and I think that's an excellent parting shot. We don't sacrifice quality for coverage. So it's a fine balance. I'm really excited to present Prof. Dussault, who is an NTP manager. He's also a professor of microbiology, as well as the director of the WHO supranational reference laboratory in Cotonou, Benin. Prof. Dussault is going to be presenting in French, So for English speakers, please select the French channel, and you can also mute the original audio so that you only hear the translators. Over to you, Prof. And bienvenue.
Merci beaucoup. Bonjour à toutes et à tous. J'espère que les difficultés d'Internet ne vont pas m'empêcher de partager cette diapositive.
Thank you very
avec
much.
vous.
Thank you
Je
for this
remercie
presentation.
la
I hope
ASLM pour
that my
l'opportunité qui
internet
m'est
will
offerte
be
d'échanger
stable so
avec
that I
vous
can stay
sur le
with you.
rôle que pourrait
And I
jouer
want to
un
thank
laboratoire
ISLM for this
supranational de
opportunity
référence de la
to
tuberculose
enable me to exchange
dans
on the
la mise
role
en
that can
œuvre de
play
nouveaux
a
tests. On a
supranational
appelé ça point of care
laboratory
test ou test
in
plus proche des
tuberculosis
patients.
when implementing a new tests. We
Nous
call it
allons
point of care or
donc
near point of
voir
care
dans un premier temps
tests.
rapidement les gaps en matière de diagnostic de la
So
tuberculose
we
en
are
Afrique.
now
Les tests recommandés
going
par
to,
l'OMS
this is
pour
the
la
outline. We are
tuberculose
going to see the gaps in
et ces
diagnostics
nouveaux
in
tests
Africa.
proches des
WHO
patients.
endorsed
Comment est-ce que
TB
nous allons les
diagnostic
implémenter
tests and the new
dans nos
tests,
différents pays? Le
implementation
rôle
of new
essentiel d'un
NPOC
réseau de
tests,
laboratoires
so
pour la
near the
tuberculose et le
patients
rôle
or
que pourrait
near
jouer
the point
le
of care,
laboratoire
and the
supranational.
role of national TB
Comme vous pouvez
laboratories,
le
a
voir
network.
dans cette
It's a role that
diapositive,
can
vous
the
voyez qu'au
play
niveau
the
mondial, le
supranational
gap en matière
laboratory.
de
As you
diagnostic
can
est
see
d'environ
in this
25%. Au
slide,
niveau
you
de
can see
l'Afrique,
that
nous avons un gap
globally
similaire
speaking,
en
we can
comparant
see
le
that
nombre de
the
cas
gap is
de
25%. In
tuberculose
Africa,
estimés,
we have
l'incidence
quite a
de la
similar
tuberculose
one.
par
If
rapport
we
à la notification,
compare
nous
the
avons un
amount
gap
of
d'environ
tuberculosis
26%,
case
similaire au
and
gap au niveau
regarding
mondial.
the notification, if
Quand
we
on vient
compare that,
maintenant au
we
niveau
see
des cas
also
notifiés
the
et que
gap
nous
is quite
voyons le
similar
nombre de
to
cas
the
notifiés par les tests,
global
le
one.
nombre de cas
So
de
when
tuberculose
we
notifiés
see the
par les tests
notified
moléculaires
cases
rapides, nous
notified
voyons qu'au niveau mondial, il y a un gap
in
de
tuberculosis
52%.
through
Vous savez
molecular
que l'OMS
fast
recommande
tests,
qu'on
we see
utilise
that
les
at
tests
world
moléculaires
level
rapides de
we have a
diagnostic
gap
comme
of
test initial de
52%.
diagnostic de
And you know that
la
WHO
tuberculose. Ce gap
recommends
est de
to
52% au niveau
use
global. Au
the
niveau africain,
molecular
on fait un
tests,
peu
as you
mieux,
know.
mais il faut voir que ce
So
gap
this
est
is the
encore de
gap of
45%.
52%, and at Africa
Et
level, we are a
même
bit
lorsque
doing a bit better,
on a pu
but
atteindre
we are still at
l'implémentation des nouveaux
45%, as you
tests,
can
il
see.
faut voir qu'il y a une
And
disparité dans
even
l'implémentation
when
de ces tests.
you
Et cette
do
disparité
the
dépend
implementation
de la
of the new
région.
test, there are some
Les pays de
disparities
l'Afrique de
on
l'Est et de
the
l'Afrique
implementation of
australe
the new
font
test, and
mieux
it
que les
depends
pays de
on the
l'Afrique de l'Ouest et de l'Afrique
region,
centrale.
on
Et quand on vient
sub-region.
même au
Also,
niveau des
Western and
régions,
Central
on
Africa
voit que
are doing
les
better
pays qui sont
compared
de
to
grande
Eastern
taille
and
s'en
Southern
sortent mieux
Africa.
que les
And
pays
also
de
at
plus petite
level of
taille.
regions,
Et
we
quand on
can
vient au
see that
niveau même des
countries,
différents pays, les pays qui ont
big countries are
comme
doing
langue
better than
officielle
smaller
l'anglais font
countries,
mieux,
and
relativement mieux
also
que les pays qui ont en partage
per language.
comme langue officielle le
For
français et
the
le
one
portugais. Il faut
speaking
dire
English,
qu'en termes de
they are doing a
recommandations,
bit
les
better
recommandations sont d'abord en
compared
anglais. Les
to
recommandations
countries
changent
with
tellement vite que
official language
parfois
such as
les
French and
recommandations
Portuguese
ont
in
changé
Africa.
avant d'être
So
traduites en
recommendations,
français
of
et a
course, as we
fortiori en
know, are
portugais.
in
Et au
English.
niveau des
This is the
pays,
source language,
lorsqu'on
and
n'a
if it
pas
changes, and it
programme,
changes quite
une
often,
coordination du
we still
programme
need to
national de
translate it
lutte
into
contre la
Portuguese and
tuberculose
French. This is
qui
maybe
est
why.
fort, une
And
coordination
we
forte et web
don't
est bien
have
organisée. On
national
a l'implémentation
program
de ces tests-là
coordination
qui peut prendre du retard
for
et des retards
tuberculosis.
de
We
plusieurs années.
must
L'OMS
be
met en œuvre,
better
l'OMS sort
organized,
les recommandations
and
et la mise
sometimes
en œuvre de ces
it
recommandations,
creates
ça prend beaucoup
delays
de temps.
sometimes of several
D'où la
years,
nécessité de
and
pouvoir faire
the
comme nous faisons là,
WHO,
réfléchir en amont, discuter
even
avec
if
les différents
they
acteurs en amont pour
ask
voir comment
us
nous
to have a
pouvons
program,
mettre en œuvre les
a national
recommandations et
program,
les
national
accélérer.
tuberculosis program, it takes
Vous savez
time.
que
So
l'OMS
it is
a recommandé
important
plusieurs
to
tests
put in place
rapides de
the
diagnostic de la
recommendation of
tuberculose à
WHO.
utiliser en première intention.
As
Il y a
you
le test
know,
G17 et
WHO
NPB
has
Ultra que vous connaissez, mais en
recommended
dehors de
different
ce
rapid
G17, il y a le
diagnostic
test
tests.
PRONAT
and
de vol bio,
with
il y a des
various
tests civiles, mais
performances.
en plus de ça, il y
And
a des
you
tests qui sont
have
basés sur
different,
des automates comme
for
Abbott,
example, the moderate
BDMAS,
complexity
COBAS,
automated
Eurotip,
NATs
et qui
for
sont tous ces
detection of
tests-là
TB
qui
and
sont
resistance to
recommandés à côté
rifampicin
des
and
tests
isoniazid. And
traditionnels
you
que
have
sont
the
la
antigen detection
microscopie
in
et
a
la culture.
lateral
Tous ces
flow
tests sont
format
disponibles, mais
biomarker-based
ces tests n'ont pas les
detection,
mêmes
and the
performances en
traditional
termes de
tests such as
caractéristiques, de sensibilité, de
microscopy and
spécificité,
culture.
de
All of it is
détection de la
available,
tuberculose et de
but
détection de
in
la résistance
performance, they are
aux
quite
antituberculeux,
different in
notamment
terms
à la
of
rifampicine, mais
characteristics and
également de rapidité
sensitivity
dans le
and
rendu des
detection
résultats
of
et également de complexité de ces
DST,
tests-là.
and
Voilà la
also
situation actuelle.
rapidity
Et
for
c'est dans cette situation
on
qu'il y a
how
de
fast
nouveaux
we are
tests
getting
qui
these
arrivent.
results. And
Ces
this is
nouveaux tests
the actual
ont des
situation. And
caractéristiques
within this
différentes.
situation, we see
Rania a
new
montré les
tests
tests qui sont dans les pipelines. Et ces
arriving
tests,
with
leur
different
objectif principal,
characteristics,
c'est
as we
d'être
saw,
plus proche
and Granias showed
des patients.
indeed
Mais
the
ces tests, pour
recommended
pouvoir être
tests
utilisés, il faut qu'ils soient
and the
fiables.
different
Il faut
ones.
que leur fiabilité
And
ne soit pas
indeed,
très
she says
éloignée.
also that
Et
we
en
need to
termes de
choose the
performance des tests
tests
actuels,
that
sinon
could
les
be
pays auront du mal à les
used
adopter.
near
Il
point
faut que
of
ces
care.
tests-là soient
And in terms
rapidement
of
disponibles et qu'ils soient
performance, I
reproductibles.
would
Et
say that
surtout,
the
et
countries will
là,
some countries
il faut
will
que ces
find it
tests
difficult
soient
to
acceptés
adopt,
par les
and we need
utilisateurs,
to adopt
notamment les cliniciens.
this test
Si on n'a pas
rapidly,
un travail
of course,
préalable qu'on fait
and
avec
must
ces
be
cliniciens, on peut avoir
accepted
des tests
by the
disponibles,
users,
mais ces tests
clinicians,
ne
as
pourront pas être
we
utilisés.
don't do
Et ces tests
work
doivent être
prior
intégrés
to
dans
that with
l'arsenal
clinicians and
déjà
other
très important de
health
tests dont on a
agents, then
parlé tout
it
à
will
l'heure.
they
On a
will not
parlé des
be
tests
used,
traditionnels,
and
microscopie
they
et culture,
need
mais
to
on a parlé
be
également les tests déjà
integrated
recommandés
in the
par l'OMS, les tests
as well.
moléculaires
So
déjà
we
recommandés
speak
par
about
l'OMS. Comment
the
est-ce que les nouveaux
new
tests,
test.
point of care, les
We
tests
spoke
proches
about microscopy
des
and the
soins,
one recommended
comment ces
by
tests-là vont être
WHO.
intégrés
So
dans les
for
tests
the
déjà
point of
disponibles? C'est
care
un véritable défi.
tests,
Est-ce qu'ils vont remplacer la
how will
microscopie
they be
là où la microscopie n'est pas
integrated in what
disponible,
we have
ou alors
already
ils vont
available
remplacer les
at
autres
the
tests qui
point
ont
of
les mêmes
care? If we
caractéristiques,
want
mais
to
eux, ils sont
replace
plus proches des
microscopy, for
patients
example,
parce que
or
mieux
maybe they will
décentralisés.
be
Dans
next
tous les
used
cas,
next
si ces
to
tests ne permettent
also or
pas
in
de
parallel to
détecter la
microscopy, or where
résistance à la
microscopy is
rifampicine, par exemple,
unavailable.
il va
So
falloir
in any
imaginer
case,
un
these
système de transport
tests,
des échantillons pour
if
que l'on puisse
for
détecter la
example, if
résistance à la
these tests
rifampicine, parce que
cannot
comme vous savez, c'est
detect
comme une
resistance
recommandation de
to
l'OMS d'avoir pour tous les
rifampicin,
patients
we will need to
diagnostiquer
use
leur
other
statut
things
par
at
rapport à la résistance à la
decentralized
rifampicine
level,
afin
as
que l'on puisse
yes,
leur
the
administrer le
recommendation
bon
of
traitement.
WHO is
Et donc,
to
ces tests-là, où
study
est-ce qu'il
the
faut les
statute of the
placer? Il faut les
patients
placer
regarding
au niveau
sensibility
périphérique et en dessous du
and
niveau périphérique
resistance
si c'est des
drug
tests proches des
susceptibility
patients.
testing, so that we can
Mais
give them
certains
the
des autres tests, il
correct
faut voir les
treatment.
autres tests
And
disponibles, où est-ce qu'on va les
regarding
placer pour avoir
this
un
pyramid,
maillage
this
général de tout le pays
periphery, we
et
need to
pour que
see
les
what
tests
is
soient
available.
vraiment
So we
utiles
need
aux
to
patients. Donc, vous
have
voyez
a
que
good mapping
le
of
réseau de
the
laboratoires qui est
country,
matérialisé
so
là,
that
ce
we
réseau de
can
laboratoires est
ensure
essentiel.
that
Et
these
quand on n'a pas un réseau
tests
qui est fort,
and
on aura
kind
du
of
mal
tests or
à
different types of
pouvoir
tests will
intégrer ces
be
tests dans l'arsenal des
available
tests
or
qui
will be the
est
best
disponible
ones.
et pour que
Otherwise, it will be
cet
difficult to
ensemble-là fonctionne
integrate these
correctement et soit
different
utile
tests
pour le
in
réseau de
the
laboratoires. C'est pour
variety
ça
with the
qu'il est
variety of
important
tests that we
d'avoir
have,
un réseau
so
de
that it can
laboratoires
be
qui fonctionne.
useful
Dans
for
notre
the
laboratoire, nous avons
laboratory
développé
network. This is why
ensemble
it is
avec notre réseau de
important to
laboratoires
have a
nationaux de
mapping
référence
of the
un outil
lab
pratique et
network and
pragmatique
a
pour
network
pouvoir
that works.
évaluer
This
le
is why
réseau de
we've done
laboratoires
an
pour
assessment of
savoir
the
où est-ce qu'il y a les
lab
faiblesses au niveau de
network
ce réseau
laboratories,
et
and
voir
it
ce que
is
nous pouvons
necessary
faire
to
pour améliorer.
assess
C'est
this
ainsi
network
que
and to know
dans un
where
projet
are the
financé par le Fonds
weak
mondial de
points or the
2019
strong points
à 2024,
regarding
nous avons
the labs
développé
in
cet
your
outil et
country.
nous avons
And
en 2022 évalué
between
les réseaux de
2019 and
laboratoires des 23
2024, we
pays
worked on that, and in
de notre
2022, we
sous-région Afrique de
assessed
l'Ouest et
the
Afrique centrale
laboratory network
nous
of
avons remarqué qu'en
23
il n'y a
countries
que
in West,
2
Central, and
qui avaient des étoiles
Central
lorsque
African
nous avons
countries,
évalué le réseau de
and we
laboratoires.
saw that
Et à
we
partir
only
de là,
have
nous
2
avons mis en
countries
place
that
un système
has
de formation, de
definitely
coaching, d'accompagnement, de mise en
2
place des
and
outils
more
au
stars.
niveau
And
des
this is
différents
why it
réseaux.
was
Et comme vous pouvez le voir en
necessary to put in
2024 à la fin du
place
projet,
a
la
system
plupart
for
des
training,
laboratoires, des réseaux de
coaching,
laboratoires ont
and
pu
support.
améliorer
As you can see in
leur qualité en
2024,
termes de
most of
gestion du réseau.
laboratories
Pour
or
dire que le
network
réseau est
laboratories
vraiment important
could
parce que c'est quand on a un réseau fort
evolve
qu'on pourra mieux
quality-wise
implémenter les nouveaux
and
outils
it
qui
is
arrivent et
important to
que
have a network.
l'ensemble
When you have a strong
de ces
network,
nouveaux
it
outils
will
qui vont
definitely
s'intégrer dans les
enable you
outils
to
existants, ça
put
va
in place
être
the
utile
new
pour le
tests
diagnostic de
and
la
the new
tuberculose.
tools
L'OMS
which will
a
definitely
défini les
integrate
étapes clés pour
the
pouvoir implémenter de
what you
nouveaux
have
outils
in your
diagnostiques.
country.
Lorsque
And
les nouveaux outils sont
otherwise,
recommandés,
it
il faut que ce soit
is
recommandé par
necessary
l'OMS.
to
À ce
implement,
moment-là,
if
il
we
faut au
want to
niveau national
implement
mettre en
new
place un groupe de travail
diagnostic test,
pour
it must
suivre
be
tout le processus
recommended by
d'implémentation.
WHO. And
Et
then
le
at
processus
national level,
d'implémentation n'est pas
you
un
can put in
processus
place a
très
working
aisé.
group
Si on
that will
saute des
follow
étapes,
all the
on se rend compte à
implementation
la fin
process.
qu'on n'arrive pas
And
à atteindre les
it
objectifs
is not
de
a costly one.
l'utilisation
Yes,
de ce nouvel outil. Donc,
it
un
has
groupe de travail.
different steps. I
Et ce
mean,
groupe de
you
travail
must
va voir
also
ce qui existe en
be
termes
careful
de ce
to
test et qu'est-ce que nous
achieve
voulons
the
faire avec ce
objectives. And
nouveau
this is
test et
why
puis
a
mettre à
working group
jour
will
les
do the
nouveaux
follow-up
algorithmes que
and
nous
will take
pouvons
in consideration what we
utiliser
want to do
désormais
and
avec ce
to
nouveau test-là.
update also the new
Après, il
algorithm
faut voir,
so that we can
évaluer le coût
use
de
this
l'implémentation de ce
with
test.
these new
Après,
tests.
acheter
Thereafter,
les équipements nécessaires, non
we
seulement les
will be
équipements, mais
able
également
to
les réactifs et consommables dont on
develop
a
a
besoin pour
realistic
pouvoir réaliser
cost
ces tests.
and then
Développer des
procure and
procédures
install
opératoires
equipment in
standardisées,
safe functional
mais ne pas
testing
oublier l'aspect
sites
clinique parce qu'on a
and
beau faire
to
les
develop
choses au niveau du
the
laboratoire. Si les
SOPs
cliniciens ne savent pas ce qu'il
and
faut faire, on ne pourra
also
pas
ensure
atteindre
a
les
reliable
objectifs.
supply of quality assured
Ensuite,
reagent and
développer un petit
consumable.
programme d'assurance
And
qualité
if
pour s'assurer que
everyone
ces
doesn't
tests
know
qui sont
what they need to
réalisés
do, we will
sont des
not achieve
tests
our
fiables
objectives. And this is
et
why we
des
need also
tests
to put
qui
in
sont
place a
assurés sur le plan
comprehensive
du
Q&A
contrôle de
program
qualité. Former les différentes personnes, les accompagner pour
with and
que les
implement
tests
also
soient
training,
réalisés
mentoring, and
correctement et
competency
enfin mettre en place un
assessment
système de
program to
suivi,
train the
évaluation
different
de cette
agents,
implémentation
health
et
agents,
voir
and
si cette
to
implémentation
put a
arrive
system in
à
place for monitor
implémenter,
and
à
evaluation
impacter le
of the
diagnostic au niveau
implementation and
national et
impact
faire les
of the new
ajustements
test. And
nécessaires lorsque ce n'est pas
if
le
we
cas.
achieve
Donc,
our
c'est
goals,
vraiment
of course, at
important de
national
suivre cette
level,
étape-là de façon
this is
rigoureuse. Ça peut
necessary
varier selon
and
les pays et selon
what
les
to do
contraintes,
if it's not
mais
the
il y a
case.
une feuille de route
So
à écrire
this
et à
is
suivre pour
very
pouvoir
rigorous
atteindre les
steps, as you
objectifs
can see,
de
and to
cette
have a roadmap, to
implémentation-là.
elaborate a roadmap
Quel est le
so that
rôle
we
maintenant
can
de laboratoire
definitely
supranational? L'Organisation
achieve
mondiale
our
de la santé
objectives.
a mis en place, comme vous
So
savez,
what
les
is the
laboratoires
role of
supranationaux
the
pour la tuberculose
supranational reference
et a
laboratories?
défini
So
des
at
rôles pour ce réseau
WHO
de laboratoires
put
supranational.
in place
L'un des rôles et le
networks
rôle très important,
and an
c'est
assistance
d'accompagner les
to
laboratoires
national
nationaux de
reference
référence
laboratories, the
pour que ces laboratoires
NRLS,
nationaux de
in the
référence soient
implementation
capables
of
de
the
mettre en œuvre les
WHO
recommandations
policy
de
guidance on
l'OMS, les
tuberculosis.
recommandations
So
de diverses autres,
these
notamment
laboratories
les
must
recommandations
be
concernant les
able
nouveaux
to put
tests
in place
diagnostiques
the
et
WHO
puis en incluant comme élément
guidelines
important
and
le
recommendation regarding the
développement
new
des
diagnostic
tests
tests
pour
and
le panel,
also
pour
to take
l'évaluation
in
externe de la
consideration
qualité de
the
ces outils-là. Et
development of
puis de
tests
vulgariser les outils en termes de
for
biosécurité,
the
mais également
quality and to
de
evaluate the
qualité
quality of
au
these
niveau
tools
des réseaux de laboratoires pour
and
la
also
tuberculose au
for
niveau national et mais
biosecurity and
également au niveau des
quality
laboratoires
at
nationaux
the
de référence. Il y
level
a
of
plusieurs autres rôles,
laboratories. So
mais
disseminate
j'ai
WHO
voulu mettre
guidance
en
on
relief
biosafety
ces
requirements
deux
and
rôles
quality management system
principaux parce
for
que ces rôles sont
NRLS
importants
and
pour
laboratory
l'implémentation des
network.
nouveaux
So these are the
de
two
diagnostic.
principal
Au
roles
niveau de notre
of the
sous-région, actuellement,
supranational
dans la
reference
région Afrique
labs
de
for
l'OMS,
the
il y a 4
implementation of the
laboratoires
new
supranationaux. Il y a
diagnostic
Alger,
test. So
Johannesburg, Kampala et
regarding
Cotonou.
our
Mais il y a il y a
sub-region
4 autres
in,
laboratoires qui sont dans le
so we
pipeline
see
actuellement. Il y a le
here
laboratoire de
four
Mozambique, le laboratoire du Rwanda, le
supranational
laboratoire
laboratories
d'Éthiopie
in
et le
West
laboratoire
Africa,
de référence
and we
de Zaria
also
au
in other
Nigeria,
regions
qui
we
sont donc
have
des
the
laboratoires
one
qui
of
sont dans le
Ethiopia,
pipeline et qui
Mozambique,
prochainement seront
and
probablement des
other, the
laboratoires
one
qui
in
vont
Nigeria, for
accompagner les autres
example,
laboratoires pour atteindre les objectifs.
and more
Donc,
that will
pour
be
présenter le rôle
able
que pourrait
to
jouer le laboratoire
achieve
supranational,
our
j'ai voulu vous
objectives.
présenter un
So
cas que nous
regarding the
avons eu
role
l'année dernière en
that
2024,
supranational
financé
laboratories could
par
play, I wanted
l'USAID.
to
Et
present
c'était
a case
d'accompagner certains
in
pays
in
pour
2024.
l'implémentation
It
dans
was
ces
financed
pays-là
by
de GeneSpec sur
USAID.
les selles,
It
par
was
une méthode
to
rapide qu'on a appelée
support
méthode
different countries
SOS.
for the
Vous savez
implementation
que
of gene
GeneSpec
experts
peut
on
être utilisé sur
stools.
les selles,
So
notamment
we
pour
called
faire
it
le
the
diagnostic de la
SOS
tuberculose
method.
chez les
As you
enfants,
know,
parce que les enfants ont du
GeneXpert
mal à
can
cracher.
not
Et lorsque on
used
peut mettre
on
en
a stool
évidence
for
l'ADN dans les selles des enfants, on peut faire le
TB
diagnostic.
for
Les
children.
recommandations ont été faites, mais plusieurs pays
Can
n'ont
be
pas pu
used as
implémenter.
for
Et nous
children.
avons
It
été
is
contactés
difficult
par
to give
l'USAID pour
sputum.
accompagner
So
certains
this
pays à mettre en
recommendation was
œuvre,
done,
à
and different
implémenter
countries
cette
could not
recommandation-là. Les
implement
différentes
it, and we
étapes
were
pour faire
contacted
court,
and
c'est que nous
asked
avons
to
organisé une
help with the
formation à
implementation of
Cotonou.
this
Cette
WHO
formation a
recommendation.
impliqué non
So
seulement
this is why we
le personnel de
organized a
laboratoire,
training in
mais certains
Cotonou,
cliniciens clés
and
qui étaient impliqués
it
dans la
was
tuberculose
for
pédiatrique.
the lab staff, but
À l'issue de cette formation
also
qui était théorique, mais
for
également
the
pratique, nous avons,
pediatric or
chaque pays
children
a développé une
tuberculosis.
feuille de
And at
route
the end of
pour
this
l'implémentation de
training,
cette,
it was theoretical
de
but
cette
also
technique-là.
practical.
À
We
l'issue de
developed a
ça, nous
roadmap
avons
for
continué le suivi
implementation
des pays en ligne et
regarding
puis nous
these
avons réalisé
technique.
après une assistance technique
Thereafter,
dans
we
ces différents
continued
pays pour
to
s'assurer que tout ce qui est
do a
outil en
follow-up with
termes
the
de
countries
procédures qui
online,
est
and
disponible dans le
then we
laboratoire, mais
provided
c'est
also
également
technical
les outils
assistance
pour
to
informer
these
les cliniciens,
countries
les notes de service,
regarding
les
uh,
différents formulaires sont
procedures
disponibles. Sinon,
regarding
on
what
a
is
aidé les
available in
pays
the
à pouvoir
laboratories and the
implémenter ces différents
roadmap
outils. Et
and the
puis,
different
on a
forms.
développé avec les pays
If it
des
wasn't, then
outils,
we
des
definitely
matériels de
help the
formation
countries to
pour qu'ils
create
puissent
this
former
form. Then
leur
also
réseau.
we
Et enfin, des
developed
outils de
with
communication
the
pour les
countries
cliniciens. Pour dire que nous
training
avons non
for
seulement
the
formé les pays,
different,
nous les avons
so it
accompagnés
was
pour que ces
definitely
pays-là soient à même de
useful. We
pouvoir
support the
implémenter
NTRL in
cet
developing
outil-là.
standard
Et
SOPs and
à
other
la
related
fin,
tools, develop customized
les
SOS training
pays,
materials for
lorsque
the laboratory
ces
network,
pays-là ont
and
été
supports
accompagnés, ces
the
pays
NTP in
ont pu
developing communication
implémenter ces
material for
outils-là dans leurs différents
clinicians.
réseaux. En
So,
conclusion,
and
nous
it
pouvons
was a
dire
successful
qu'il y a dans le
implementation, as
pipeline
we
de
can see on
nouveaux
these
outils
photos with the big
de
smiles.
diagnostic
And
qui
in
vont venir et qui vont
conclusion,
venir
we can
pour
say that in the
s'intégrer
pipeline we
dans
have
les outils
new
qui sont déjà
tools
disponibles.
for
Et
diagnostic
donc,
that
il
will
faut
come
pouvoir
in the future that
réfléchir
will
pour
be able
voir comment
to
on les
be
intègre
integrated
dans,
in
dans les
already
outils
available
existants pour
tools.
qu'ils soient complémentaires de
And
ces outils
we
et
need to think
permettre à
how
ce
to
que ces
integrate these
outils
in the
ensemble
actual
permettent
tools so
d'améliorer
that
le diagnostic
they
de la
can
tuberculose. Et pour
be
ce
an
faire, il faut
addition
avoir un
to
réseau de
these
laboratoires
tools,
qui
and
est
that
performant. Parce
with all
que sans un
tools we
réseau de
can
laboratoires
uh,
performant, il est
enhance
difficile de pouvoir
the
implémenter les tests de diagnostic de la
tuberculosis
tuberculose de
diagnostic,
façon
and we
générale.
need
Et
to
pour ce
have
faire,
a well-performing and
l'assistance du
useful
laboratoire supranational sera
strong
très utile et nous sommes
laboratory
disposés, nous,
network, and
avec
this
les
is
autres laboratoires
why
supranationaux,
the
pour accompagner les différents
supranational
pays afin
structure
que l'implémentation de
is very
ces
useful,
différents
and we
outils-là
are at
soit un
your
succès.
disposal
Voilà ce
to
que je voulais
continue
partager
to
avec vous. Je
accompany
vous
country
remercie.
for the implementation of various tools to make it a success. This is what I wanted to share with you, and I thank you for your kind attention.
Merci beaucoup, Prof. Thank you so much for that wonderful presentation. I think you have given us a lot to reflect on what will be needed to implement these new tools. So we have a couple of questions in the chat, and Grania, thank you so much that you were responding to those. We are also running a poll. If you could please take a moment to give us your feedback on where you think these tools would have the greatest impact in your country programs. And as you do that, we'll go through the questions. So please also put your questions in the Q&A box. And we'll also reflect on some of the thoughts that you are sharing within the poll. So I'm going to ask a question to both Grania and to you, Prof. And it's a question that comes to really tease through the issue around the missing people with TB, or that diagnostic gap, Grania, that you spoke about. And in Prof's presentation, he did show that this diagnostic gap appears to be declining somewhat over the years. And the question is, so this means that potentially the tools that we are currently using are making some impact, even though they are expensive, yes. So then why do we need these new tools? Again, to your point earlier, Grania, around the trade-off between sensitivity and coverage. So the question is really trying to understand what is the added value that these tools will bring to the TB diagnostic cascade. Over.
So are you happy if I go first, maybe? Yeah, I think that's a very excellent question. And I think we have made progress. It's slow progress, but it's getting there. And I think this is just adding a tool to the toolbox, because I think if you have very good coverage of WRDs in your context, and maybe your issue isn't necessarily the diagnostic gap, it's more the active case finding of kind of how are you going to find the people to offer the tests, then maybe this tool is not as important to you as it could be for some programs where your WRD coverage is 60%, 50%, or even under that there your diagnostic gap for a quality WHO recommended diagnostic gap is quite large. And then what is the cause behind that? Is it a purely financial component, or is it? So I think it's that, and as Prof Disu was saying, is really getting to know your network and know your challenges. So I think this is just because this new product is arriving doesn't necessarily mean that it is suitable for everyone, or it's going to address every issue you have in that diagnostic cascade. But what I think we do feel is that it really offers a real opportunity to think innovatively around, is there an opportunity to take to, for example, if a platform costs $500 and doesn't have any service and maintenance, could you put a molecular test at every TB treatment site in the country? Could you put it at every microscopy site in the country? Because your upfront investment in doing that is not as much. And then therefore, kind of, you've got a molecular test that is available that can give a result in under half an hour at a healthcare site that is linked to TB treatment. And then it can take some of the time pressure off your sample transportation, and it sort of maybe makes it easier to fit into some of the sample transportation, say for the HIV test, where they have viral loads, which are a reflex test. So if you get a result back the next day or in 5 days, it's not as important as this is the test that you're going to start treatment on. So I think we see that globally, this test could really help bridge that 52% gap we see in the UN HLM target. But nationally, regionally, districtly, that's up to the sort of programs and the people planning for it to see which is a gap that it can fill. Is it cost? Is it quality? Is it decentralization? Or is it not actually helping your particular problem? Thanks.
Thanks, Grania. Prof. Diesel, any additional reflections to that?
Oui, bon, Grania a dit l'essentiel.
Yes,
J'aimerais
Grania
ajouter
said
que,
it all, I would
oui,
say,
le
but I
gap
would
est
like to
multifactoriel. Et
say
le gap,
that
les
gap,
raisons qui expliquent ce
the
gap
reasons
ne sont
indeed
pas
that
identiques
explain this
dans
gap are
les
not
mêmes
identical
pays,
in
tous dans tous les
different
pays de la même
countries
façon. Et comme Grania
in
l'a
the
dit,
same
même à
way. And
l'intérieur du
this
pays,
is
il
exactly
peut y
what
avoir des
Grania
différences
said.
d'une région à
Even
l'autre.
inside a
Et
country,
donc,
you can
tout
have
ça là va
differences
être
from a region to another
étudié.
region.
C'est pour ça
So this is why it needs to be
qu'il est vraiment
studied. You need
capital
to see, and it is
qu'on ne prenne pas un
essential
outil comme ça et
that
que l'on
you
dise
don't
on va
take
l'implémenter
such
parce
a,
que si on
for
n'essaye
example,
pas
tool and say,
d'analyser, de
let's implement it. No, no, no.
contextualiser
You need
notre
to
problème, on aura du
contextualize
mal
the
à être
issue
efficient.
and
C'est
see,
pour ça
identify
que c'est important que
what
chaque pays puisse
where it could be
se
efficient. And
réunir
this
avec
is
les
why
acteurs. L'aide des laboratoires
each
supranationaux
country must
est là et vous pouvez l'utiliser à
try.
tout moment
And I mean,
pour que
we
les
have the
pays puissent
supranational
voir dans notre
referent labs,
contexte
and we can
comment est-ce que
help.
nous
And
allons
we
intégrer
can
cet
see in this
outil-là
context
pour
how
que
to
cet outil nous soit
integrate
bénéfique.
these
Donc,
tools
c'est
so that
vraiment
it can
important
be
de
really
faire ce genre
efficient
de
and to
travail
our
avant d'aller à
advantage.
l'implémentation.
It is
Merci
necessary
beaucoup.
to do
À
this
vous.
study before you implement it. Thank you.
Thank you very much, Prof. I think that is very clear. And I just want you to respond to a question that came through from Guy. And it's really speaking to programmatic implementation. And he says that speaking of the state level working group for the implementation of the new test, is it the PNT that is setting it up alone or the Ministry of Health? And how can we make the implementation of the new diagnostic tools in our countries truly effective? It's also posted in French in case I got the translation wrong, but please respond to that, Prof. Thank you.
Yes, indeed. So he speaks about the working group at national level. Who is putting it in place, the PNT or the health ministry, and how it will be, how can it be efficient, or can we guarantee the efficiency of these new tools in diagnostic tools in our countries? Thank you, Guy, for your question. Yes, the PNT or coordination of the PNT, rather, it is the representative of the Minister of Health that is in charge of dealing with the tuberculosis in each country. So it is the Ministry of or Minister of Health with the PNT at national level. This is the way you have to see the PNT. And particularly in the actual context, we need a team that needs to think about the implementation of new tools. It is not only for people that work for the coordination of PNT, as you need to have an interaction. For example, you have to do that with other program, interaction with HIV, for example. It is necessary to take in consideration the interaction with the Ministry of Health for the HIV, for example, or you have also the general health centers. So such team must be a team that includes different skills and, of course, under the coordination of PNT, as it is the PNT that will be able to solve problems and will be in charge of coordination. So it will be under the coordination of PNT, but it must include other actors from other sectors so that it can be implemented. So for it to be efficient, well, we put in place such a group, a team, and then we need to think how to integrate these diagnostic new tools to what is existing already, to the existing tools. If we don't do that, we can't succeed. And otherwise, we must also get support and follow up, or coaching and follow up, so that it is integrated successfully. This is what I can say to respond to this question. Thank you.
Thank you so much, Prof. And that's a nice segue into the next question that is talking about integration. So what other non-TB tests are available on these POC or NPOC platforms that will enable integrated testing across disease programs? And also related is a question around what exactly do we mean by near point of care, and how is it different from point of care testing? So if you can address that, and I think I'll give that question over to Grania.
Thank you, and very good question. So I think from our awareness, the Plus Life platform, which is the kind of new platform and the new manufacturer in this space, has a number of other cartridges that work in their mini-doc platform. They don't have, from a global fund perspective, they don't have the ERPD or the WHO PQ approval, but they do have tests for SARS, flu A, flu B, MPOC, strep, RSV, HPV, strep B, and a few others. So those are what the company has available from the global fund perspective. They're not through our relevant quality assurance processes, but they are available for procurement. And Lucy, apologies, I've forgotten your second. What is a near point of care test versus a point of care test? Yes, so I think the WHO target product profile has begun that process of trying to define that, and there will be at the WHO guideline meeting in November further clarity on what is a near point of care test. But I think in broad strokes, it is a test that does not need any major lab infrastructure. It does not need any technical lab training, and that it doesn't need things like a stable electricity supply, as a approximate broad strokes of what a near point of care test is. Thank you.
Thank you so much, Grania. And I almost don't want this discussion to end, but unfortunately we are approaching the top of the hour. So I will just start with Prof to give just a few closing remarks to this session, and then I will then ask Grania to give a few words, and then we'll close out the session. So over to you, Prof.
Thank you very much, Lucy. It is a pleasure to have been with you and the different colleagues online. And sorry if we couldn't answer all questions. And indeed, we can continue this discussion in your countries to see how we can enhance diagnostic of tuberculosis in our countries. And there are different tools available, but despite all these tools, it is difficult to close the gap regarding TB diagnostic because we are not using in a good way all the tools, or maybe we have other constraints regarding the use of these tools. So definitely we need to facilitate this task, and to do so, we need to really study how to integrate these tools with the existing ones to achieve our objectives. But to succeed, we need to have a lab network, a strong one. And this is why I encourage you all to work on this reference lab network, so that we have a strong network that will enable us to implement new diagnostic tools and to close the gap for TB diagnostic. Thank you so much, and a very good afternoon to all.
Grania.
Thank you. Yeah, so I hope that everyone is seeing the excitement and the potential that we have in the TB diagnostic space with an entirely new class and a product that not only allows us to think outside the box, outside the lab, and allows us to think outside sputum. So we have two really exciting possibilities coming up that the WHO will hopefully give guidance on in November, and then with a rapid communication afterwards. And I think, to Prof. Disu's point, to make this a success, I think we all need to work together, both on the TB programs, the lab programs, and our affected communities, to drive demand and to ensure that these new platforms and these new sampling techniques are used in the right way to really help us accelerate closing that diagnostic gap whilst maintaining quality. So we look forward to continuing this dialogue. As I shared, we did the TB Day with ASLM last year, and we hope to continue this dialogue at the LabCoP meeting in November. And I think very much I see 2026 and 2027 being the year where we can further accelerate our coverage of the WRDs and ensure that we find and treat everybody with TB. Thank you.
Thank you so much, Grania. And I see some comments around funding cuts, but unfortunately we no longer have time, but we'll provide the questions to our speakers and they will provide the answers and those will be sent over to you. So thank you everyone for attending, and apologies for going over, but thank you for making the time to be with us. And we hope to continue these discussions within our country teams, our technical working groups, as we seek to close that diagnostic gap. Good afternoon, good evening, and good morning to all of you. Good day.
Thank you very much.